you guys missed out. And I think I will go next if that's okay, just because I'm at another meeting. So I will go next with the endoscopic approach, and then Dr. DeRusso will give his talk again afterwards. So let me just share my screen here. Okay. All right. So I'm going to go over some of the anatomical landmarks of the carotid via the extended endonasal approach and also ICA rupture management. And I'd like to thank my fellow Solomon and Renan, who have been doing a fantastic job in the lab and also with this presentation that they were helping me with. So, you have this, we just went over some of this beautiful radiographic sort of images of the carotid. And so, and Dr. Froelich is gonna go over how you see this from intracranial. But as you're thinking about the carotid artery endonasally, you always have to consider where it is on the endonasal approach and then where it is in comparison transcranially. So you always have to keep this three-dimensional picture in your head because what you the landmarks are similar, but a bit different. So you have to sort of know it and keeping these landmarks in mind. So we have the ascending or parapharyngeal portion of the carotid artery, the horizontal petrous, the lacerum and anterior genu of the carotid, and then the paraclinoid. We'll sort of focus in more detail all of these different segments. And these are the anatomic landmarks that we'll go over in more detail. So the parapharyngeal carotid artery. So essentially this goes from the common carotid bifurcation to the ICA foramen of the petrous bone. In the neck, it's going to run inside the carotid sheath, medial to the internal jugular vein and intermedial to cranial nerve 10. But really, when we're talking about the endoscopic endonasal approach, it's really the parapharyngeal ICA superior to the level of the heart palate that becomes relevant to this approach. And your landmark essentially is it's going to be posterior to the lateral most extent of the cartilaginous eustachian tube. So you have the cartilaginous eustachian tube here. And then posterior to the lateral most extent of this is where you're going to, if you draw a line back, you'll see the carotid artery, the parapharyngeal carotid artery is going to be right there. So this is with all the soft tissue removed. But you also, other landmarks you want to look at is the levator veli palatini muscle, which you see here, and this is attached to the eustachian tube. And then if you look at the fossa verosimillar, which is here, just deep to that, on the deepest aspect, if you follow that posteriorly, and you can see the same thing here, if you follow that posteriorly, you'll find the parapharyngeal carotid artery. So you want to keep your landmarks in place, and that includes the eustachian tube, the levator veli palatini, and the fossa verosimillar. So here we go again. It's located in between the levator veli palatini and the stylopharyngeal muscles, and it is covered by this thick basopharyngeal fascia that you have to go through in order to have full exposure. And so here is with the eustachian tube cut, and you see the levator veli palatini muscle here, and you're going to see the parapharyngeal ICA just deep to that, and attaching to this basopharyngeal fascia. And importantly, this parapharyngeal tubercle is a really good anatomic landmark. So if you draw a horizontal line across the parapharyngeal tubercle, what you'll see is that leads you to the carotid foramen. So it's a good landmark for the identification of the distal parapharyngeal ICA, and it's really in a straight line on both sides. And here it is again, and you can see the carotid foramen here as well as on this side. So when you identify that parapharyngeal tubercle, once you've gone through that basopharyngeal fascia, you can go here, and then you'll find the carotid foramen. Then heading over to the petrous segment of the carotid. So this segment goes from the carotid canal of the petrous bone to the posterolateral aspect of the foramen lacerum. Distal to that, it really is just going to be just juxtaposing the clivus bilaterally. So it's kind of got this this three-point thing. It goes into a vertical. There's a vertical segment, a bend, which is the posterior loop, and then the horizontal portion. So we'll go over each of those. And your landmarks here is really going to be the Vidian canal. And you have to find the Vidian canal, and it's really the line of fusion between the pterygoid process and the floor of the sphenoid sinus, and I'll show you a picture of that. And then the pterygoid wedge, where the medial pterygoid plate meets the floor of the sphenoid sinus, and then V3 is also a good landmark. So if you go here, you essentially, the transpterygoid approach is really what allows you to have endoscopic access to this region. And the pterygoid process has the pterygoid bone has two processes, the sphenoid process and then the orbital process. And the sphenopalatine artery is going to go from the pterygopalatine fossa to the nasal cavity. And then the Vidian canal is going to be inside the pterygopalatine fossa. So if you remove the sphenoid process and the orbital process, you'll find the Vidian canal. And you'll have to drill all around. So this is the sphenopalatine artery. You want to coagulate and cut the sphenopalatine artery, and then that's going to allow you to go to draw to here's your Vidian canal, and you want to drill circumferentially around the Vidian canal. And then once you get to the Vidian canal, you'll get to the pterygosphenoidal fissure. And once you get here, this is kind of the safe entry zone to the lastrum segment of the carotid artery. And so it creates this 15-degree angle here. This is a nice imaging picture of that, the pterygoid tubercle, which is going to be a 45-degree angle between the Vidian canal and the pterygosphenoidal fissure. And that really provides you the safest entry zone to the lastrum segment of the carotid artery. So keep that in mind. The foramen lastrum is really going to be that gap between the sphenoid, the petrous, and the clivus. That gap is actually forms the foramen lastrum, and you want to enter that at the safest entry zone, which is at which is going to be at the pterygoid tubercle. So this becomes a very important landmark to be able to find that anterolateralmost aspect of the foramen lastrum segment. Then we get to the paraclival carotid artery, and this goes from the posterolateral foramen lastrum to the superior edge of the petroclival fissure. And there, this is an important part. You got to like identify the bony landmarks as well as the soft tissue landmarks, and that's important throughout the whole endonasal approach. Essentially, what you have here is, so you have your maxillary strut, right? That's a bony landmark that we know, and we have the lingular recess, and the lingular recess is really going to be what you intracranially, and I think Dr. Froelich will point this out, is intracranially corresponds to the lingular process of the sphenoid bone. So the pneumatization of that is this lingular recess here. And so if you draw a horizontal imaginary line proximal to this line along this lingular recess, you're going to have the extracavernous segment of the paraclival carotid artery, and then distal to it, to this imaginary line of the lingular recess, you have the intracavernous segment. And then intracranially, if you think about that, the petrolingual ligament is going to connect the lingular process to the petrous apex and marks the lower margin of the cavernous sinus. So you have to think about, what this lingular recess here corresponds to intracranially, and that's the lingular process. And intracranially, we'll see the petrolingual attachment, and that really marks the entry of the carotid artery into the cavernous sinus. So again, the configuration here around the lastrum segment, it really sort of acts like a foot in a sock, which is why it's actually called this ICA sock. This is a paper from Amin Kassam describing sort of these different segments, and it really describes this thickened sort of fibrocartilaginous band around the ICA, which is the ICA sock. And it is an important landmark for identifying the proximal part of the paraclival ICA, especially if you have, not poor pneumatization of the sinuses, you depend more on the soft tissue exposure. What are the cranial nerves that are associated with the paraclival carotid artery? So mostly cranial nerve 5 and cranial nerve 6. So cranial nerve 5, you can see that proximally to the upper edge of the petrolingual ligament, the paraclival ICA is going to be medial to the lower 2/3 of the Gesteirian ganglion, and then more rostrally, it's going to enter the cavernous sinus. Importantly, the cranial nerve 6, there's different segments that you can see through the endonasal approach. There's this sternal segment, then there's this intradural segment, and then it bends over the petrosal process of the sphenoid bone to go almost horizontal behind the ICA, and then goes up in towards Dorellus canal and then into the cavernous sinus. So those are the two cranial nerves associated with this region of the paraclival carotid artery, and you can see it here sort of making this bend over the petrosal process of the sphenoid bone. And that can be actually identifying the nerve here where there is a bony landmark allows you a little bit of safety when in protecting the 6th nerve. Then you get to the paracellular region of the carotid artery. So from the supermedial portion of the petrous apex to the proximal dural ring. And actually, this part of the carotid artery is more widely separated from the carotid sulcus. The other parts are more surrounded by bony landmarks. So this is kind of what we would describe a little bit more of the free-floating carotid artery, and some landmarks are going to be the sellar floor and the petrous apex here. And it's the only segment that's really located inside the cavernous sinus. And then within it, the contents within this region of the cavernous sinus, medial to the paracellar, is going to be the venous component of the cavernous sinus, and you have all of the different paraclival ligaments, which you have to be able to cut through in order to resect the medial wall of the cavernous sinus, and those have been nicely described. Then lateral to the paracellar ICA is going to be where the abducens nerve passes, and it's going to be adherent to the vessel on this surface as well. And then even further laterally is where you find the other nerves that are going to control extraocular movement. Then you get to the paraclinoid segment of the carotid artery. And again, important to identify both bony structures as well as the fibrocartilaginous structures. So some of the important bony structures that we find here, or some of the important structures we find here, is going to be the medial and the lateral OCRs. And the lateral OCR being the pneumatization, this triangular shaped pneumatization that represents the optic strut when you're thinking about it intracranially. Then you have the medial OCR, which is this teardrop picture here, and it's formed just at the medial junction of the paraclinoid carotid canal right here, and the optic canal. Importantly, you want to think about your lateral tubercular rhesus, which corresponds to your tubercular crest intracranially, and that's the bony indentation at the lateral most extent of the tuberculum sella. And then finally, you want to identify the distal osseous arch of the carotid sulcus, which is going to connect the lateral tubercular recess to the medial aspect of the lateral OCR, and it kind of overlies the distal dural ring right here. So that it's that bony, this is kind of what we call the distal osseous arch of the carotid sulcus. Always keeping in mind what these things relate to intracranially, and I think we'll go over that in more detail. Then the proximal dural ring, important to know that it's an incomplete and incompetent ring. It does not fuse tightly with the arteries adventitia. And the distal dural ring is more complete. The proximal dural ring can be, if there's a middle clinoid, there will be a more thickened band, and therefore the proximal dural ring can be more complete if the middle clinoid is present or if the middle clinoid is more prominent. The distal dural ring, in contrast, is complete, and it fuses tightly with the arteries as adventitia. And then immediately distal to the distal dural ring, you see the ophthalmic artery takeoff, as we saw in the last presentation. So importantly for your approaches for each of these, if you're talking about the parapharyngeal artery, you're really talking about the lower 1/3. So you're talking about your transcrival transodontoid. If you're doing the endonasal approach, the petrous, you're talking about infratemporal fossa, but you can also actually do the far medial approach that was described by Gardner's team, but that will get you to your petrous carotid artery and allow you to be able to mobilize the carotid artery laterally if you do a petrosectomy. Your paraclival, you're talking about your transclival approaches, and then finally paracellar and paraclinoid, those are going to be your transcellar, transtubercular, transplanum approaches. So here's just what everyone's sort of looking for. I'll fast forward through the beginning of this, but this person had been previously operated on transcranially, and unfortunately was blind in one eye and was worsening. The vision began to decline in the other eye, and so then we're doing a transplanum transtuberculum approach, and you'll see here that one of my fellows gets into the carotid artery. And so let me fast forward because the approach is not so important, but we want to talk about how to manage these, right? And so you'll see that is drilling with a diamond drill there. And it's important to notice here, because a lot of these expanded approaches, we're doing, there's not a big mass expanding the sphenoid sinus. There it is. So oftentimes the anatomy is not so clear cut, right? It's not like a big pituitary gland, and so it's not so clear cut, and so you have to be very careful. So you see here that there's an ICA injury right there, and at that point, you want to get there it is. You want to hover your suction to see where the injury is, right? If there's that patty is altogether way too big, but you want to hover your suction to really see what the injury is. Most of the times, you know, if you try to coagulate or if you try to put any sort of mechanically stop this, oftentimes you end up making the hole bigger. There are very few times in which you can actually clip, you know, put an endonasal clip if that's the case. But what you want to do is, you know, obviously get the bleeding under control, let the anesthesiologist know. This is a piece of crushed muscle that works very well, and you want to sort of switch out your patty for the crushed muscle and then go directly to the endovascular suite. So here's an example of the muscle. You also want to be, interestingly, you do want to give heparin. You don't want to forget to do that, right? And you don't want to occlude the vessel too much. So you want to really hover your suction, see where it is, put a patty on briefly just to control the bleeding while you're able to switch out for that muscle. So now that there's muscle there, I'm going to put a Maricel in there to be able to go to the endovascular suite. I keep a patty on top. I go to the endovascular suite. And this person ends up getting a stent across. They ended up getting one of those cardiac stents, so dual antiplatelet. And interestingly here, the angiogram didn't show any defect, but don't be, if you saw a carotid injury, you know, don't think that, oh no, it's fine and go back in. If you saw carotid injury, you definitely need to fix it. There are some people who say, well, maybe you can just get an angiogram in a week, but oftentimes you'll see a pseudo aneurysm. Those are very high risk of rupture. So I think it's safest if you see a definite injury to go ahead and put a stent in. And this is the stent that this patient had placed. Obviously, we were not able to remove the tumor, and because of the stent, it's a covered stent. So this person ends up getting dual antiplatelet for 6 months, and then we'll come back in and replace and take out the tumor, probably transcranial at that point. But a couple important points from this video is, you know, when you're doing these tumors that you don't have great landmarks, you have to be very cautious. And when you do get an injury, you want to really control the bleeding, put some muscle, and you got to remember to tell the anesthesiologist to give heparin. So how do we prepare for this? The best way I think is to prepare through this via the carotid injury model. And this was widely described by Gabizada and his group. You know, they really created this perfusion-based human cadaveric model for management of carotid artery simulation for the trainees. So the objective really is to train residents so that when this happens intraoperatively, it's not the first time that you've experienced this or that you've dealt with this. And so the materials that you need, you're going to need a fresh, unfixed cadaver head. Do this pretty easily, but you do have to have a perfusion system that allows you to pump blood substituting through the carotid. So you access the carotid in the neck, and you create this perfusion system. So here's an example. Here's the perfusion system connected to this patient's neck. This is the head here. And then the session begins. I actually went in and I created a carotid injury, and then you begin training for this. So you have, I did the exposure, I did the approach, and then there's going to be the trainee who's going to come in, right? And then at the same time, we are monitoring the vitals of the supposed patient, right? With EKG, pressure, and heart rate. And then if they're not able to get this under control within 5 minutes, the patient, you know, goes ahead and dies. So we have this training model. You know, this is one of my trainees, and the injury is already made in the carotid artery, the perfusion system set up. And I'll show you just a video of that. And again, the technique is really to replace the suction with a large bore suction. That's the first thing you want to do, and it saves time in the long run. And then hover the suction to attempt to visualize the injury, place the patty, and then go ahead and switch it out for your crushed muscle. So I think this video will pay. Here we go. So that's the injury there. So you can see that it's very quickly fills up with blood. Some of the trainees won't switch out the suction right away, and that's actually a mistake. So you do want to switch out to a large bore suction, right? Then you want to communicate to the anesthesiologist that you've had a carotid injury, get blood available in the room, and actually give heparin. And you want to hover it over the injury to be able to see exactly where it is. In the meantime, somebody is getting the crushed muscle, and you're going to put a patty there, and then switch out the patty for the muscle. So the patty is there, you know exactly where your injury is, you're able to get the bleeding under control. As you can hear, the patient starts to, you know, the heart rate starts to go up and the pressure starts to go down as time passes, sort of simulating a real life Okay, so here's a piece of crushed muscle, and the idea is that you're going to switch out the crushed muscle, which, yep, this can happen. And then, yep, now the crushed muscle is directly over the injury. And once you clean up the field, that's considered a successful repair of the carotid injury. So this is I think a very useful training model. We kind of timed them. So you do this twice. Once you do it initially, and then you hear about what the technique should be in terms of the hovering and switching it out for the muscle. You learn the technique, and then you do it again. And what we found is that the time to control the bleeding improved by almost 50%, and the amount of bleeding reduced by about 50%. And this is exactly what they found in Dr. Zada's experience as well. So this is something that we've done in our lab maybe once a year, once every other year to train our residents. But importantly, you have to go to the lab to learn these anatomic landmarks, learn where there can be injury, and then, use this carotid injury model to prepare and prevent disaster when this happens intraoperatively. So I'll stop sharing my screen. I think now, if Paolo, if you're able to go again, I think that would be great, because you had some great content there and we missed out on most of it. But maybe you can start after the classifications. I think we heard most of the classification.
Can you hear me now?
Yeah, we can hear you now.
Seems better than before.
Yeah, much better. Not breaking up at all, actually.
Okay, so let's try. Thank you.
Perfect.